Theoretical and practical questions of the non-invasive measurement of arterial stiffness. Part 5. The arteriograph. The first method and device measuring arterial function, stiffness, with a single upper arm cuff. Here we can see the working principle of the arteriograph. The most important issue is the suprasystolic cuff pressure. That means that we pressurize the cuff higher than the actual measured systolic blood pressure. This way, the brachial artery will be completely closed, and at the upper edge of the cuff, a trunk and membrane will be developed. This membrane will be beaten by the central pressure energies, and because of the energy remaining rule, this energy will be transmitted into the upper arm tissues, which are mostly containing fluid. Thus, they are uncompressible. Consequently, without any damping, this kind of energy packages will reach the boundary of the skin and the highly pressurized cuff, and the skin will dilate very gently, compressing the cuff, and the volume decrease will go to increase in the pressure in the cuff according to the Gauss rule. These very gentle pressure changes will be driven by the hose of the cuff into the high fidelity pressure sensor of the device, and then very high fidelity and very high quality pressure changes can be obtained with this method. We can see the first direct systolic wave, we can see its reflection from the aortic bifurcation, and we can see the diacritic valley, diacritic notch, and the diastolic waves. We validated the working principle of the arteriograph. In this X-ray picture, we can see the humeral bone and the needle representing the upper edge of the arteriograph cuff, and here we can see the intra-arterial intrabrachial catheter, which was positioned just slightly higher than the upper edge of the cuff to be able to obtain edge pressure signal from the brachial artery simultaneously with the arteriograph measured pressure signals. Here we can see the pressure signals obtained invasively at different cuff pressures. At the suprasystolic cuff pressure, when the brachial artery was completely occluded and stop flow condition developed, the capability of recording the first and the second systolic signal was perfect. Here we can see nicely separated first direct systolic wave and its reflection, and then the diacritic wave and the diastolic wave. However, if we drop the pressure and then the cuff pressure was between the systolic and the diastolic pressure, the flow was maintained during the whole cardiac cycle. Bernoulli effect developed because the diameter was diminished due to the cuff pressure, and we can see that the shape and the position of the second systolic signal has changed. This is quite similar that kind of signal which is obtained during applanation tonometric method. However, when we drop the pressure to the diastolic blood pressure in the cuff, and the flow was completely maintained during the whole cardiac cycle, and what is more important, the brachial artery was not compressed and applanated at all. In this situation, the capability of recording the first and second systolic signal completely disappeared because only one wave was seen in the systole. Conclusion: only the suprasystolic cuff pressure signal provides separated and reliable pressure signals for the further analysis. How to measure augmentation index with the suprasystolic oscillotic method can be seen in this picture. The heart ejects the blood into the aorta, creating a pulse wave which propagates through along the aorta until the bifurcation of the aorta and will be reflected. Obviously, these changes could be detected by the cuff, the highly pressurized cuff, which completely occludes the brachial artery. The first and second wave amplitudes can be measured easily, and then what is important, that the second systolic wave amplitude is mostly determined by the actual peripheral vascular resistance. The formula which describes the difference between the first and second systolic wave is called augmentation index, which formula says that the second systolic wave amplitude minus the first systolic wave amplitude divided by the pulse pressure, which is the difference between the first and the second systolic wave, multiplied with 100. The higher the peripheral vascular resistance, the higher the second systolic wave amplitude, the higher the augmentation index, and vice versa. How to measure aortic pulse velocity with the suprasystolic osteometric method can be seen here. The time between the spikes of the first and the second reflected systolic waves, this time is equal for the travel of the pulse wave going down to the aortic bifurcation and to come back. This is called return time. The return time is divided by 2, then we can get 1 go. This is the aortic propagation time. If we measure the distance between the sternal notch and the pubic bone, which is called jugulum symphysis distance, we can get the distance which is proportional to the aortic length. According to the formula, the velocity is equal distance divided by time, so the sternal notch and pubic bone distance, in other terms juxi distance, will be divided by the return time per 2, and then we can obtain the aortic pulse velocity in meter per second. Let me emphasize again that these received pressure curves, the first and second systolic wave during the suprasystolic osteometric method, is not influenced by the brachial artery characteristics at all because the artery is completely blocked. We have strong evidence which supports the working principle of the arteriograph regarding the reflection site in the aorta. In the paper published in 1905 in the Zeitschrift für Biologie by Otto Frank, who was a famous and very excellent physiologist in Munich, who pointed out that the reflection site in the aorta is about 50 centimeters far from the aortic arch, and it is available at the aortic bifurcation. This scientific fact proves the arteriograph working principle. In the following, I would like to demonstrate the relationship between the central aortic augmentation index and the actual peripheral vascular resistance. In low peripheral vascular resistance, the arteries and arterioles are dilated, thus the energy which is in the pulse wave is driven towards to the periphery, thus the original energy will decrease going towards to the aortic bifurcation. The result is that the reflected energy will be small, creating the smaller amplitude in the aortic pressure wave and also in the brachially recorded pressure wave. However, in case of peripheral vascular resistance increase, for instance due to endothelial dysfunction, the small arteries and arterioles are closed and less energy can be driven towards to the periphery. Thus, a large energy package will reach the reflection site, the aortic bifurcation, and it will cause a large amplitude in the aortic pressure wave and also in the brachial pressure wave. What kind of new parameters we can measure with the arteriograph? A newly developed parameter is the diastolic reflection area, which provides information about the left coronary perfusion conditions. The area of the diastolic wave reflection and the duration of the diastole are assessed together in this parameter. This is an example. In case of normal augmentation index with normal peripheral vascular resistance, the diastolic reflection area is 50.7, which is normal. However, in case of increased peripheral vascular resistance, featured as increased augmentation index, the diastolic wave almost disappears, and then the diastolic reflection area value decreased to 11.8, reflecting a poorer diastolic flow condition to the left coronary artery. Here we can see the characteristics of the left coronary artery blood flow in different parts of the heart cycle. During the isoelectric contraction time and during the systole, basically no flow can be seen in the left coronary artery, only in the diastole, featured as C part of this cycle. This is very important because the left ventricle is perfused by the left coronary artery. Thus, it is very important how good or how bad or left coronary artery filling conditions during the diastole. The higher the diastolic reflection area is, the better the left coronary artery perfusion conditions. So what can we measure with arteriograph? We can measure the augmentation index, which reflects to the peripheral vascular resistance and to the endothelial dysfunction. The aortic pulse velocity provides information about the vascular characteristics and the arterial wall characteristics of the aorta. Basically, the more rigid, the stiffer the aortic wall, the higher the aortic pulse velocity. Vice versa. If the aortic wall is elastic, the aortic wall is not stiff, the pulse velocity is low. The third parameter which we do provide is the ejection duration of the heart, which reflects to the duration of the mechanical systole. Formerly, I mentioned the diastolic reflection area, furthermore the systolic area and the diastolic area index. These parameters help to judge the left coronary filling conditions. The systolic and diastolic blood pressure and the heart rate measured as well in the brachial artery. Furthermore, the arteriograph provides a very important parameter, which is the central aortic systolic blood pressure and pulse pressure. If we try to position the augmentation index and the aortic pulse velocity in the genesis and the timeline of the atherosclerosis, we can conclude that the augmentation index will show first the problem and the disease developed as endothelial dysfunction or vascular dysfunction, and it is very early when the augmentation index will start to be positive and increased. Later, developing the atherosclerosis and vascular calcification, the arteries will be stiffened and the aortic pulse velocity will increase, and this is going towards sunset, to our more advanced age. Finally, due to the pathological process, stroke, myocardial infarction, and peripheral arterial disease will develop. The question whether these pathological changes such as atherosclerosis and increased pulse velocity could be reversed today is not an easily answered issue. We do have some trials such as Camelo, Reversal, and Asteroid. When administering a large dose of statin or calcium channel blockers, revealed that they were able to reduce the vascular calcification and the area of the coronary plaques. However, the data are still not enough, and then further studies are needed to prove whether the developed atherosclerosis or vascular calcification can be reversed or not. If we take a look on the atherosclerosis timeline, and if we take into consideration that today, in the most cases, we can see our patients when they have symptoms with complicated lesions and ruptures such as microinfarction, unstable angina, or stroke. This situation when we can start to treat and intervene. Unfortunately, this is rather late. So, by measuring the arterial stiffness with this excellent new method, Arteriograph, we can conclude that we can detect and recognize the pathology much earlier in the endothelial dysfunction stage. Thus, it allows us to implement sufficient intervention to prevent, to develop a very costly and very deadly disease such as complicated rupture and lesions, and the clinical occurrence of the atherosclerosis such as stroke, myocardial infarction, and unfortunately sometimes death. So this early diagnosis allows us to prevent the later developing complications. Thank you for your attention.